Okay, and welcome to the Davies Use Kids webinar being presented by University of North Carolina Healthcare on improving care for patients with suspected or confirmed heparin-induced thrombocytopenia. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. Davies Award-winning use cases have been peer-reviewed to validate sustainable improvement in business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers from UNC Health. We have with us Kaylin Rohde and Jennifer Stegall-Zanation. Kaylin and Jennifer, I will turn the presentation over to you, and you can begin when you're ready. And thank you for joining us today.
Good morning and welcome to the case series presentation for the HIMSS Davies Enterprise Award. Today we're going to be talking to you guys about our case series titled Improving Care for Patients with Suspected or Confirmed Heparin-Induced Thrombocytopenia. We are located at UNC Healthcare. So my name is Kaylin Rohde. I'm a medical ICU clinical pharmacist at UNC Medical Center.
And I'm Jen Stegall-Zanation. I'm an informatics pharmacist with UNC Healthcare.
So just to provide a little bit more background about UNC Healthcare System, we are an integrated not-for-profit healthcare system owned by the state of North Carolina and based in Chapel Hill. You can see some of our statistics here regarding our licensed beds, employees, medical staff, et cetera. And our health system includes 10 hospitals that are located across the state of North Carolina. The case study that we're going to talk to you guys about today occurred mainly at UNC Medical Center, which is located central in the state. Additionally, you can see kind of all of the different awards that our institution and our health system has been successful in achieving, listed here on this slide. So first, let's dig into our local problem related to our case series. So today we're going to be talking to you a lot about heparin-induced thrombocytopenia, and the first thing I want to talk about is how this is related to medication safety. So over 12 million individuals are exposed to heparin each year in the United States. Of those 12 million, about 1 to 5% of them will go on to have a complication called heparin-induced thrombocytopenia. This is a very serious complication related to heparin administration, and it increases patients' morbidity and mortality. And how this occurs is actually an immune-mediated process. So when patients are exposed to heparin, they have antibodies that are created that will bind to their platelets and a heparin molecule, which will lead to thrombocytopenia and also thrombosis. And as you can imagine, the management strategies around this disease state are actually very complex. So it includes discontinuation of all heparin products. You have to perform appropriate laboratory testing to confirm diagnosis. You have to initiate alternative anticoagulants to avoid heparin, and then if patients are confirmed diagnosis with this complication, you have to document heparin allergies and ensure that patients are educated about this diagnosis moving forward. This is a lifelong diagnosis, so that's why it is key that patients understand what it means for them as they are exposed to healthcare systems in the future. And one thing to know about it, too, is that if you continue heparin administration to this population, it increases their risk for hypercoagulable state and increased risk for thrombosis. So in our eyes, this is how this is related to medication safety, is that if we're able to discontinue heparin upon diagnosis or upon testing of these patients, you could have a large impact on your potential preventable adverse drug events within your institution. So within UNC Medical Center, this problem was first identified using internal medication error reports. So we had cases where patients were reported to continue to receive heparin despite HIT testing pending or being positive, which this led us to doing a retrospective review from April 2014 to May 2016. And again, this revealed a huge significant opportunity for us to improve our safety of our patients undergoing HIT testing within our institution. So the first figure you'll see here is this bar graph, and what this is showing you is heparin product administration based on HIT testing results. So in our pre-implementation phase, the dark bar describes our HIT testing pending patients, so we continued heparin in about 50% of our patients with HIT testing pending. Additionally, we continued heparin in about 15% of our HIT testing positive patients and 40% of our patients that were HIT testing indeterminate. This table here also describes we were interested in looking at allergy documentation at discharge, as this will, again, ensure that patients or other healthcare providers would understand this diagnosis if they were readmitted to our institution. So what this table describes is the bolded rows are appropriate allergy documentation based on HIT testing results. So for example, for our HIT testing positive patients, about 93% of our patients appropriately had an allergy in the chart. For our HIT testing negative patients, about 94% of our patients appropriately had no allergy in the chart. And then for HIT testing indeterminate patients, 100% of those patients appropriately had an allergy in the chart. The two groups that I do want to highlight are HIT testing positive patients that had no allergy documented. So when we did this retrospective review, we identified 2 patients who left our institution without an allergy in the chart. This is a huge medication safety risk, as these patients could be readmitted to our institution and inadvertently administered heparin, which would, again, increase that morbidity and mortality for those patients. Additionally, for our HIT testing negative patients, there were 30 patients who left our institution with an allergy in the chart. So we're going to talk more about these patients in later slides, but this could potentially be a huge cost savings for institution, as those patients, we would be administering alternative anticoagulants to them instead of heparin due to this allergy documented, even though they were never positive for HIT. So moving more into the design and implementation phase of this, so we tried to create multidisciplinary workflows and a number of different processes to help alleviate this local problem that we identified. So step 1 was that we created a multidisciplinary team, and as you can see here, this team was composed of pharmacists, physicians, laboratory staff, ISD, and also nurses. And one thing you'll notice is that the roles and responsibilities of each of these team members mainly was that they were content experts in their field of practice, but we were all electronic health record end users as well. So we were trying to develop a multidisciplinary workflow and modifications to our electronic health record that would help alleviate this issue, but again, that all end users would be easily used by all end users within our team. We had a number of different goals and objectives and also strategies that we used to help with this problem. So as I mentioned earlier, our overall goal was to improve the safety and management of patients with suspected or confirmed HIT. If we were able to achieve this overall goal, we would effectively reduce the number of possible preventable adverse drug events within our institution. So the 2 objectives that we created is that we wanted to, number 1, prevent heparin administration in suspected or confirmed HIT, and also improve appropriate heparin allergy documentation at discharge. So the 5 strategies we implemented is we created evidence-based guidelines, we created a multidisciplinary workflow, we modified our electronic health record, and then we also implemented patient education programs and our first ever heparin-induced thrombocytopenia stewardship program. Step 3 of our process, after we had created our goals, objectives, and multidisciplinary team, was actually thinking about what did this multidisciplinary guideline and workflow look like, and we also looked for feedback from a number of different groups within our institution. So idea generation around the guideline and workflow mainly came from our multidisciplinary project team. Additionally, we had clinician review by our benign hematologist physician group and then our coagulation laboratory group. And then the workflow was reviewed by the Acute Care Service Pharmacy Practice Council, which is our council that is a number of different pharmacists from all of our different service lines sit on that council, so they approved the workflow from a pharmacy standpoint. Additionally, we had Nursing Practice Council that reviewed the workflow from a nursing standpoint. And then for process implementation, our Medication Safety Committee, Pharmacy Informatics Committee, and also our Student and Resident Advisory Committee reviewed the workflow. The Student and Resident Advisory Committee was mainly due to that we incorporated a pharmacy resident on-call program, which we'll discuss later as well. And then lastly, we went through our Pharmacy and Therapeutics Committee for final approval. Just to give you an idea, so this approval process led to 18 different versions of our workflow and electronic health record modifications. So we did receive a lot of feedback from all of these different groups. Step 4 was creating our timeline and our approach to this problem. So we started back in 2015, so it was almost a 2.5-year endeavor. And we started out by first, again, reviewing those medication error reports that we discussed earlier. We assembled our project team, and then we created our goals and objectives. And then from there, we jumped into our retrospective chart review, our guideline development, the multidisciplinary workflow creation, and then also our electronic health record modification. We took about 4 months for committee approval and review, and then we implemented our staff education. So we educated nurses, pharmacists, physicians, pharmacy residents. So there were a number of different groups that we highlighted the workflow and the guidelines with. And then our go-live date was actually November 1st of 2016. And then since that time, we've been reviewing the process and collecting data on our process and completing formal PDCA cycles to assess for possible improvement, areas for improvement within our workflow and guidelines.
So one of the things that came out of this entire process was how to do a multidisciplinary workflow in the EHR. And so the group assembled and developed what they thought would be important key design elements that they wanted within this workflow. And so initially we decided, well, should we do an order panel versus an order set? At the time we were live with Epic 2014, so order sets and order panels were searched differently. And so the team decided that it would be, for ease of use, better to go with an order panel to make it a more upfront workflow for the end users. The other nice thing about the Epic panels is that you can actually still have easy access to clinical guidelines. So hyperlinks were put in those panels so that people could see our Gatraban protocols and also, as Caitlin was talking about, the guidelines for the management of HIT. Also, it would allow us to pre-check items and have more multidisciplinary communication. So we could have nursing orders and pharmacy orders and also lab orders all within the same panel. One thing that was kind of a build that we had to create was there was no once in 8 hour frequency within our system, so we actually did have to associate that new frequency, test that new frequency with our heparin-induced thrombocytopenia panel and our other lab tests that we would be doing for low risk. So we also have been working on doing these PDCA cycles, which are plan, do, check, act cycles. And so there has been 4 of those that have actually been reviewed by the multidisciplinary team. After those are reviewed, barriers are determined, and EHR modifications, if necessary, will actually come out of that group. So PDCA cycle 5 is still ongoing. It started in June 2018. So to go a little bit more deeply into these PDCAs, the first one was cycle 1, and that was from November 2016 to January 2017. So at that point, we noted that some of the barriers were a low utilization of the order panel and also inadvertent HIT laboratory testing orders done outside of the panel. So some of the modifications that came out of the multidisciplinary team's review was to make the order name of the panel more distinguishable. So as you can see on your left, the original order panel might be named Argatraban Intermediate High Risk, 4 T-scores, 4 to 8, algorithm for HIT and HIT-T. And so then we changed it to, after the implementation of PDCA, we changed it to just say HIT panel and low risk with the name of the drug at the end of it. The other thing that came out of that was that some of the organization wasn't actually as designed, and so to make the lab test stand out more, we actually moved up those in the panel, then having the medications, and then having the nursing orders and the consult to pharmacy labs. Another thing that we noted when we did PDCA 4 was that there were still physician workarounds identified. So in that time frame, we actually had implemented our Epic 2017. And so we decided at that point we could utilize the nesting panel functionality. So we consolidated basically 6 different panels down to 1 panel, and we were able to make it single select. So the provider at that point would select low risk, intermediate risk, pediatric, or a documented history of HIT. Once they selected that risk stratification or patient population, then it would bring in the management orders, our Gatraban orders, and also standard orders. Standard orders were actually implemented at this time because we actually noted that the providers were unselecting nursing and pharmacy orders, and so to make it stand out more, we made a nested panel that kind of in red said standard orders for nursing and pharmacy staff with all of those still pre-checked, hoping that physicians would not unselect those orders and realize that they were important. So our intended goals for this entire process were to improve the safety and management of patients with suspected or confirmed HIT by reducing the number of possible preventable adverse drug events. And so our goal was to create a multidisciplinary guideline and workflow. So our second one was to prevent heparin administration in suspected or confirmed HIT, and so our goal was to have less than 5% of patients exposed to heparin while testing was pending. Our third objective was to improve heparin allergy documentation at discharge, and our goal was really 100% of patients would have appropriate allergy documented at discharge.
Moving more into what exactly we did to leverage health IT to help, again, create these electronic health record modifications. The first thing we did is we developed out this workflow, and just to give you guys an idea of what exactly that looks like. So this slide is demonstrating what our workflow looks like pre-go live on the top and then post-go live on the bottom. And down the center, what you'll see is each of the different steps of the medication use process. So our process is around prescribing, pharmacist verification, administration, and monitoring. What you'll notice in our pre-go live workflow, there was no process in place for administration or monitoring. And now in our post-go live workflow, we have a lot of different processes to kind of help ensure that we're managing these patients appropriately at the bedside and also following up with them before discharge.
So when you look at the actual prescribing level of this workflow, you can see that some of the key aspects are now we have an order panel that places all the management orders in one location. Prior to implementing this multidisciplinary workflow, providers had to find all of their necessary orders as a la carte, so they would have to find their lab, their management, their nursing orders, and consult the pharmacy separately. We also now have a distinct area where they can hyperlink out to the clinical guidelines without having to go outside of EPIC to do that. We also are ensuring that they get the heparin labs ordered at the appropriate lab time. Previously, they were ordering them at once, and that was not giving enough time for the heparin to be washed out after the heparin infusion was stopped. So now that we have a defaulted once in an 8-hour lab time, those are actually being drawn as a proper timing. And now we have multidisciplinary communication orders to not only our nursing staff, but also to our pharmacy staff, which is important in this workflow. So when we look at the pharmacist verification aspect, they will get the consult order as an in-basket message. And when they get this, they will then go through the steps of documenting a temporary heparin allergy on the patient's profile. So as you can see here in our screenshots of the heparin allergy workflow, the pharmacist screens the profile and discontinues any heparin-containing products if they haven't been done already. They will add a temporary allergy to the electronic health record system. And then providers and nursing staff will then receive a warning when heparin-containing products are ordered. Also in this pharmacy workflow, we have a smart phrase that the pharmacists are using to bring into a note, and that will allow them to document what medications the patients are going to be taking, what kind of stage is the patient in, what their 4T documentation, and then also and then they will follow up with a secondary pharmacy note after this to finalize the documentation.
So looking more at our process around administration, so as Jen had mentioned, the pharmacists are responsible for entering a temporary allergy into our electronic health record. The reason that we chose this is that it allows for nursing staff in any area of our hospital to receive a warning if they scan any heparin-containing products. So this example on our screen here is going to be the pop-up that the nurse will receive if, for example, she scans a heparin flush when this allergy is in place. So this allowed us to ensure that patients in different areas of the hospital, so for example, if they're in dialysis, the operating room, or even interventional radiology, all of those nurses will receive the same warning. Other things that we had discussed within our project team was thinking about maybe wristbands or signs that traveled with the patient, but again, they are not very transparent to all providers, whereas this allergy will be a great way to kind of flag these patients and ensure that administration is avoided. Additionally, the two orders that the nurses receive out of the physician order panel is that there are two miscellaneous nursing orders. So the first one is for them to use normal saline flushes for all central venous access devices. And then additionally, they receive an order to place the patient on heparin allergy precautions. So this is an example of what this looks like. So the nurses will place this sign at the bedside for any patients on heparin allergy precautions. And again, it's another visual reminder for anybody entering that patient's room not to administer heparin to those patients. And then lastly, looking more at our workflow around monitoring. So now we have key steps in place that will ensure that all of the laboratory testing is followed up in a timely manner. So now what happens is once all these tests finalize throughout the week, the laboratory staff will page the pharmacy resident on call with the results, and then they in-basket message the pharmacy resident all of the results and their thoughts on the results as well. Pharmacy resident on call then contacts the service pharmacist to develop a treatment plan, and then the service pharmacist writes a final consult note as well and provides recommendations to the team. And then lastly, we implemented the HIT stewardship pharmacist role. So every Friday there's a report that's generated that allows the HIT stewardship pharmacist to review any HIT panels that were sent in that previous week, again, to ensure that all of the laboratory results are followed up on and appropriate allergies are documented in our electronic health record. And then the last part of our monitoring phase is ensuring that our patients are educated appropriately when they leave our institution if they are positive for heparin-induced thrombocytopenia. So what you'll see here is that this role is actually shared between our nursing staff and pharmacy staff, but if a patient is positive, they provide them with this allergy card that's available through our print center. And then the idea is that the patient will be able to present this card to any provider across the nation or any institution that they're admitted to for future admissions, and that way, the physician will have a better idea of what exactly happened when they were exposed to heparin in the past. And then lastly, we do provide them with a patient-friendly handout that just describes this diagnosis and why they have to avoid heparin for future admissions. So next we'll discuss some of the value that was derived from this process that we implemented.
So as you can see, we have a pre-implementation group that had 542 patients, and that was from April 2014 to May 2016. Our post-implementation group had 270 patients from December 2016 to May 2018. And the baseline demographics have been similar between the pre- and post-implementation groups. And as you can see at the bottom of this table, patients with diagnosed with HIP has stayed the same. So 5.5% in the pre-implementation and 5.9% in the post-implementation group. When you look a little bit further at HIT heparin product administration based on HIT testing results, so in our previous slides, we had shown that pre-implementation with the HIT test pending, we had 50.9% of patients still receiving heparin, and that number has been reduced to 20%, which is a significant p-value of less than 0.05. When you look at our HIT testing positive patients, previously we had 15%, and that number has been reduced down to 12.5%. It was at 0%, but unfortunately we had an incident in a single nursing unit that caused that number to increase recently, and so we are going to focus on single service education on that nursing unit. When you look at the HIT testing indeterminate, though, 40% pre-implementation, now down to 0% in the post-implementation group. So there has been a significant reduction. When you look at the trends in our monthly kind of HIT testing pending, you can see that there are some variabilities in those monthly trends, and we have attributed those to providers unselecting the pharmacy consult orders. So hopefully now that we have more standard orders, that will be happening less. Also, what's been noted is that they've been removing the heparin allergy before the final results have come back. and that has led to heparin administration and not receiving the warnings that they should be receiving. And then lastly, we have had some patients that must receive heparin, and those are noted on the slide. We did have a significant number of ECMO patients in this last group of months, and they had to receive heparin. Looking back at our documentation at discharge, so as previously we did in the pre-implementation group have 2 patients that were missed that were HIT test positive prior to discharge. Now, as you can see in our post-implementation group, 100% of our patients are being accurately documented with HIT test positive at discharge, and none of those patients are being missed. If you look at our HIT test negative patients, previously we had 30 patients who had an allergy documented that truly should not have been, and that number has been reduced to 0%. So now we have a negative cohort that has 100% of their allergy documentation being done correctly. And the indeterminate group has stayed the same.
We dug into our data a little bit more deeper to see exactly what our workflow compliance looked like for each of the different components. So what this table is demonstrating is each of the different workflow components and then how that has changed from our PDCA-1 all the way through our PDCA-4 cycle. So for example, our 4T score documentation has improved to about 50% of patients in our PDCA-4 cycle. Additionally, temporary allergy documentation in our electronic health record has improved up to 78%. And then initial profile review performed by our pharmacist is now being completed in about 76% of our patients. Follow-up profile review performed by a pharmacist is now up to 69%. And then just highlighting our compliance with the complete bundle, meaning that every step of the workflow was completed, is now then up to about 32% of our patients. So overall, what you'll see is that for each PDCA cycle and modifications to our electronic health record, we've been able to improve our compliance over time. We also wanted to determine which step of the workflow was the most successful in preventing heparin administration. So what this table is demonstrating is the percentage of patients that continue to receive heparin with each of the different workflow components. So for example, in the first row, we have heparin given when a 4T score was documented. That occurred in about 7% of our post-implementation patients. Heparin given when temporary allergy was in electronic health record occurred in about 5.9%. Heparin given when a pharmacist performed initial profile review was in about 6.3%. And then heparin given when the complete bundle was performed was about 6.8% of patients. So the 2 workflow components that we feel are likely the most successful in preventing heparin administration are likely the temporary allergy documentation and also that pharmacist profile review, again, and just preventing that heparin from being administered with testing pending. We did assess more of our cost savings, or performed a cost savings analysis as well, and I mentioned that we were going to come back to these HIT testing negative patients earlier in the presentation. So just to remind you, so we had, in our pre-implementation group, we had 30 patients who left our institution who were HIT testing negative but still had an allergy documented in their chart. We looked more closely at those patients to assess how much we spent in alternative anticoagulants. And what we found is that we had about 35 days of inappropriate argatroman administration to those 30 patients, which led to about a $34,000 potential cost savings had we deleted out that allergy during their previous admission. Additionally, we had 17 days of inappropriate fondaparinux administration, which was about a $2,000 potential cost savings. And then we had 5 patients who were discharged home inappropriately on fondaparinux. And if you've ever tried to get insurance approval for fondaparinux, you know how difficult that can be and how expensive that can be for patients. So that could have been a potential cost savings directly to our patients as well. So now we've eliminated that. So now we have, again, 0% of our patients who inappropriately have this allergy documented in their chart when they are truly negative. So we're avoiding this cost of inappropriate alternative anticoagulant use in our post-implementation group. Another outcome that we didn't really expect to have an impact on, but we did, and what this figure is showing here is laboratory order volume per month based on each of the PDCA cycles. So in our pre-implementation phase, we sent about 24 panels per month, and you can see that this trend has been decreased over time. So in our PDCs 3 and 4, we've been steady at about 13 to 14 panels per month. And then on the bottom of the screen, you'll see kind of the total cost of testing that our institution is spending. So although it's not a dramatic decrease in cost, it still is kind of a significant number just to point out that we have been able to eliminate potentially inappropriate testing of patients with this workflow in place. So just to summarize, the value we've derived with this workflow is that we've had a significant reduction in the percentage of patients who receive heparin products with HIT testing pending, which again is a reduction in potential preventable adverse drug events within our institution. Additionally, we've had an improvement in appropriate allergy documentation at discharge, and then we've demonstrated those cost savings to our institution by minimizing future use of alternative anticoagulants in HIT-negative patients, and again, more appropriate use of HIT testing. Looking more at our next steps with this project, so there are a number of different objectives we have. So number one, we do want to start to expand this workflow out to the other hospitals within our health system. So currently this workflow is live at our UNC Medical Center and also our satellite campus in Hillsborough. Again, the goal is as we get more of our hospitals onto Epic, we would actually expand this workflow out to them as well. Additionally, we're publishing and sharing our results where we can, so we're continuing to share these within our UNC Healthcare. We are looking for future publications after we complete our results, so we're anticipating after PDCA 5 or 6 to being able to publish these results as well. And then we were the recipient of the American Society of Health System Pharmacists Foundation Award for Excellence in Medication Safety. So this award did come with a $50,000 grant that we're using to expand our efforts, and we'll talk about where we anticipate using that grant. And then lastly, we did present during the ASHP Medication Safety Best Practice webinar series as well. So with that grant, two of our objectives are we want to develop a formal patient education video. So again, this can be accessed by any institution to educate patients who are diagnosed with HIT. So currently we're relying on allergy cards and also nurses and pharmacists to use a handout. But ideally we would create this education video that again could be brought into the room and played for the patient so they understand what exactly this diagnosis means and how this will affect them for the rest of their life. And then lastly, we do want to create the first national HIT registry. So as I mentioned as well is that this diagnosis, we rely heavily on the patient to remember what exactly happened, when it happened, and what that means for them going forward, and that they should never be exposed to heparin again. So this registry would hopefully improve the transparency of this diagnosis, and right now we're looking at an Epic-based platform utilizing Care Everywhere and MyChart. So again, we can improve the transparency of this as patients receive care across the nation. And with that, we would like to thank you for your time, for listening to our case series today. And we appreciate the HIMSS Davies Award for recognizing our institution as well.
So we would like to thank our speakers from UNC Healthcare today for joining us and presenting their Davies use case. I want to remind our listeners where to go find this and more important Davies use case webinars. That information can be found at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Thank you for listening and have a good day.